Good afternoon, everyone, and thank you for joining today's event. A reminder to the reporters on the line, please press *1 to enter the queue. You will be limited to one question and one follow-up. With that, I hand it over to Minister of Mental Health and Addictions, Sheila Malcolmson.
Thank you so much, friends. Thank you for joining us today. I recognize that we are on the traditional territory of the Songhees First Nation and the Esquimalt First Nation. I also want to recognize I'm thinking of home today. I come from Snuneymuxw territory. The news this week of the affirmation of what has been known about unmarked graves on Penelakut Island, the former Cooper Island Residential School, is just one more wave of revelation and a very hard time and a time of truth. I recognize that impact on the people that we serve. I also want to send thanks to everybody that's working hard on the front lines in the wildfires this week and send our strength to those who are at the brunt of the impacts. Today I'm with Dr. Bonnie Henry, BC's Provincial Health Officer, Dr. Shannon MacDonald, the Acting Chief Medical Officer of the First Nations Health Authority, and Dr. Matthew Chow, the President of Doctors of BC. We are here together to take another step responding to British Columbia's overdose public health emergency. Far too many people in British Columbia have died from toxic drug poisoning, and many listening have lost loved ones in recent days, weeks, months over this particularly hard last year. I extend my condolences on behalf of the province and the Premier to everybody who's missing a family member or a friend. British Columbia is in the 6th year of the overdose emergency with more than 7,000 lives lost. It is tragic and it is unacceptable. And for people working on the front lines of this crisis, who have been working so hard to save lives, this is particularly hard to accept that the pandemic has represented such a setback in that work. That we are still losing lives is unacceptable. I also recognize that many working on the front lines have themselves lost friends and peers. For people who use drugs or care about someone who does, keeping safe in this public health emergency is front of mind. So our government is delivering new and innovative solutions that work together to help people stay safe and to access the supports that they need and deserve. That's why today we are expanding prescribed safe supply in British Columbia to separate people who use drugs from the increasingly toxic illicit drug supply. This builds on the work that we've been doing over the past year. At the start of the pandemic, we provided access to some prescribed safer supply to separate people from the increasingly toxic illicit drug supply. Thousands of people took this up. But we've heard from people who use drugs and from medical professionals that more options and expanded access to safer supply are needed. Today's new policy builds on what we learned during the pandemic and includes input from many partners and stakeholders, including people with lived and living experience, doctors, nurses, pharmacists, health authorities, and Indigenous-led organizations. This new policy will help to separate more people from the poison supply, to connect them to ongoing health care and support, and to stabilize their lives. We are investing $22.6 million arising from this April's budget for the next 3 years, directed to health authorities to implement this expanded policy on prescribed safe supply. These funds will support planning, phased implementation, monitoring, and evaluation of prescribed safer supply products. This means that once fully implemented, more people who use illicit drugs can be prescribed a broader range of safer alternatives covered by pharmacare, including a range of opioids and stimulants as determined by each program and prescriber. This new policy was developed within the limits of the Federal Controlled Drugs and Substances Act, which requires controlled substances to be provided by prescription. BC is leading the country as the first province to offer prescribed safe supply. And we have had to introduce prescribed safe supply carefully, responding to the urgent need for solutions and supporting patient safety and prescribers at every step of the way. During the first phase of this expansion, prescribed safer supply will be available in existing health authority funded programs that currently offer substance use services, through newly created programs such as service hubs and outreach teams supported through Budget 2021, and through existing federally funded SAFER programs. This expansion work is already underway with every health authority in BC. We've built in rigorous monitoring and evaluation to ensure that we're on the right path, and further phases will expand access once that clinical guidance is developed based on this evaluation. Everyone's working as quickly as we can to implement existing safe supply programs and to build further capacity as we bring more prescribers on board and get new programs online. I thank the courageous doctors and nurse practitioners who work tirelessly to prescribe safe supply, that do this work already, and who back this policy, this new policy that will help more people in British Columbia get the care and the support that they deserve. This kind of change only can happen through a groundswell of collaboration, and I thank everyone who's contributed to this work to date and has worked over this past year with our ministry's Overdose Emergency Response Centre to get this policy moving. We know there is more work to do. There is no silver bullet to end the overdose crisis. And prescribed safer supply is one tool within a comprehensive set of health interventions to help keep people safe and access the support they need, the supports that they need, including treatment and recovery. Just as there are many paths into addiction, there are many paths out, and so we are working hard to offer people options. As we continue to grapple with the overdose emergency, I'm thankful for the good work being done on the ground, saving lives every day. Because of this good work, and the many life-saving interventions brought in since 2016, modeling says that over 6,000 lives have been saved. This new policy will help save more lives. With that, I introduce BC's Provincial Health Officer, Dr. Bonnie Henry, to add some remarks. Thank you.
Thank you very much, and good afternoon. As we are in the tragic 6th year of the toxic drug overdose crisis, public health emergency here in British Columbia, and as the Minister has indicated, since then, more than 7,000 people in British Columbia, our friends, our family, our community members, have lost their lives to a poisoned drug supply. And for every life cut tragically short, there are countless more lives that have been changed forever. Our parents, grandparents, children, friends, spouses, and community members left behind, mourning the loss of a loved one, and no more so, tragically, than in this past year and a half, where we've not been able to come together to support each other. This is a tragedy for all of us as British Columbians, and my thoughts are with everyone who has lost somebody they love to this crisis as well. As we have grappled with the overdose emergency, we have learned and continue to learn the many steps we can take to address the harms. Steps like overdose prevention sites, supervised consumption sites, the take-home naloxone program, which has saved lives across this province, and increasing the number of youth and adult treatment beds have all made a difference, and in many cases, saved lives. But since the onset of COVID-19, the already toxic drug supply has become even more dangerous, and we have seen that in all parts of BC over this past 18 months. And measures we needed to take to respond to this pandemic have led to a record number of our family, our community members' lives lost to this toxic drug supply. And while we continue to reduce the risk of COVID-19 from our collective actions across the province, the risks from this highly toxic illicit drugs remains greater than ever. This is why this is so important to expand the access to prescribed safer supply, to separate people from this toxic drug supply that we know is there now, every day, to offer medications and connect people with the supports that they need to ongoing health care and other needs, Expanding access to safer supply is a vital step that also helps us reduce stigma around people who use drugs and better support people who need this help. A little over 2 years ago, I provided guidance on how we could do this together in British Columbia, ensuring that as we expand access in a way that protects people who use drugs and prescribers, and that we learn as we go, including making sure that we have independent evaluation to put the evidence together to continue to do the best possible programs that we can. We also know that this toxic drug supply is putting people who use drugs at extremely high risk for overdose, for the complications of that, and for death. So expanding access to safer supply will save lives. And also importantly, we have learned that with addiction, connection is so important. And this is another mechanism that we can connect people to other parts of the service of the healthcare system or housing or even getting a meal for a day. Things that can make a difference in the chaos that many people's lives are and help them reach that point where things like treatment may be an option. It means now that this access, expanded access, means people who use drugs in all settings will have access to an alternative to the toxic street drug supply. There is no one single measure that is going to get us out of the toxic drug crises, but this is one more step in the right direction. Prescribed safer supply is another important tool in our toolbox that will help keep people safe and help them access the supports they need. We have said all along, it is not about harm reduction only, it's not about treatment only, it's about building up the full continuum of the tools that we need to make a difference for people's lives. Substance use, as we know well, is a health condition and must be approached from a holistic health perspective. And I will continue to call on federal, provincial, and municipal governments to ensure our public health care and community supports reflect an understanding of that reality. And this includes, of course, the work that we're doing on removing stigma through things like decriminalization of people who use drugs. The COVID-19 pandemic has shown us as a community what is possible when we come together to support one another through a crisis. And thanks to the support of doctors, nurse practitioners who have worked through this pandemic to deliver safer supply during the emergency, as well as the efforts of countless others who are supporting people at risk of overdose death. We are making progress, but it is never fast enough or enough. With the toxic drug emergency still before us, I call on everyone in BC to keep responding with the same kindness and compassion that we have shown each other throughout this entire pandemic, and make sure that we can continue to support our loved ones and we move through this next phase. Thank you very much, and I'd now like to introduce Dr. Shannon McDonald, the Chief Medical Officer of the First Nations Health Authority.
Thank you, Dr. Henry. Minister Malcolmson, I want to acknowledge the Lekwungen-speaking people of the territory of the Esquimalt and the Songhees and all of the nations who First Nations Health Authority serves. This is a story about all of us. I also acknowledge Dr. Chow and look forward to his words. I wish we didn't have to be here today. I wish that the work we did 5 years ago, 6 years ago, was enough, but it's not. I want to acknowledge the losses, the sons and daughters, mothers, fathers, brothers, sisters, friends, leaders, elders who have lost their lives to this toxic drug supply despite all the work that's been done. And given the significant impact of illicit and toxic drugs on BC First Nations, the FNHA is supportive of new and innovative approaches aimed at reducing overdose events and deaths due to toxic drugs. And the FNHA commends the BC government for the work to date. on this new initiative and other work that we've done together over time, and for seeking the First Nations Health Authority's input. Implementation of the BC government's prescribed safer supply provides important tools to help reduce toxic drug overdose death among First Nations people who continue to be overrepresented as compared to the rest of the population. While a safer supply will decrease the chances of overdose due to unknown factors experienced in the illicit supply, there are some potential challenges related to the rollout of this program that ensure that it fulfills the cultural, health and wellness needs of First Nations, and especially for those who use drugs. While prescriber safe supply will be beneficial for many in some specific populations and potentially in some specific geographies initially, it will form an important connection between primary care workers and people who are using drugs. We know that there continues to be barriers for Indigenous people based on differential access, mistrust, and racism experienced in the healthcare system, and to the lack of connection with primary care services in general. So the work of our partnership continues. The Prescriber Safe Supply Program is asking regional health authorities, agencies, and healthcare providers to work to create guidelines for the administration of the program. For First Nations people, there is a risk of inconsistency in approach across the province and among individual communities with potentially variant outcomes. We are spread thin as First Nations Health Authority, and all of those tables require our presence and our input. And I'm hoping that there will be some patience that allows us to do that. We need to continue the conversation, providing education and support to our healthcare professionals who may need to be a little more comfortable with taking on this task associated with providing safer medical-grade alternatives to street-level illicit toxic drugs. We don't want to limit the number of care providers who choose to participate in the program, so we want to make sure that all of the services in education, training, and support are available to them. The FNHA looks forward to working closely with the provincial government, with our partners at the PHO, health professionals, and local communities to ensure that this new program meets the needs of First Nations and that there is a successful engagement process to make that happen. Thank you. And I am honored to introduce the President of the Doctors of BC, Dr. Matthew Chow.
Good afternoon, everyone. I'm pleased to join you today from the traditional territories of the Siksika, Kainai, and Piikani First Nations, the Tsuut'ina First Nation, the Stoney Nakoda First Nations, and the Métis Nation Region Number 3. BC doctors look forward to increased actions aimed to reduce the harm from illicit drugs that are killing so many British Columbians. I speak from my personal experience of losing patients and mourning with families. I'm a child and adolescent psychiatrist, a specialist in mental health, and I'm pleased to say that due to the efforts, the Herculean efforts of people like Dr. McDonald, Dr. Henry, and this government, I have not lost a single young patient to COVID-19 during the duration of this pandemic, but I have lost patients to overdoses. And in fact, during this pandemic, my daughter, 7 years old at the time, personally witnessed a fellow human being overdosing and being resuscitated. This crisis touches and affects us all. Doctors of BC's policy statement on the drug overdose crisis from earlier this year encourages efforts to separate people from the toxic, illicit drug supply, prevent unintentional toxic drug poisoning and overdoses, improve access to safer pharmaceutical alternatives, as well as improve access to a range of community-based, culturally appropriate, evidence-informed substance use prevention, harm reduction, treatment programs, and services. This ongoing crisis has had lasting detrimental impacts on people who use drugs, their families, communities, our first responders, healthcare providers, and the healthcare system. These actions, which we speak of today, are urgently needed. Thank you, Minister, Dr. Henry, and Dr. McDonald.
Thank you, Dr. Chow, Dr. McDonald, Dr. Henry, and everybody who has worked to build this expansion of our prescribed safer supply policy being released today. Thank you all for sharing and joining in this announcement to share your insights about what this expanded policy will mean for British Columbians. So to the media, we're now open to taking your questions. Thank you.
Thank you very much, Minister. A reminder to reporters on the line, please press *1 to enter the queue. You will be limited to one question and one follow-up. For our first question, we go to Camille Baines, Canadian Press.
Thank you for taking my question. We know that diacetylmorphine's been used for decades in Europe, and I'd like to know why it's not part of this policy as well.
Thank you for the question. We are absolutely open to including diacetylmorphine, and this policy really does open up that avenue. It identifies absolutely that people need more options than have been available on the menu of prescription over the last year. We are taking a phased approach. And one of the reasons that diacetylmorphine is not on this list is that access to domestic supply has been a real challenge. We are going to continue, as we will with other substances as well, and continuing to build on the evaluation and monitoring that's built into this program. We'll continue to add more prescription options onto the list of what is available through this expanded prescribed safe supply program, and that will include diacetylmorphine. Thank you. Oh, please, Dr. Henry.
I think it's important to recognize one of the things that this program will start with and has been used in the past year and a half is fentanyl and fentanyl patches. And the biggest amount of evidence that we have globally, it really is around diacetylmorphine. But what we have now with the toxicity of what we are seeing on the streets is a whole generation of people who are now have been using fentanyl and carfentanil and other synthetic opioids that are mass produced and as we know, are highly unregulated. So what we are finding and what we've heard from practitioners who've been supporting people in this past year and a half in particular is that people who are addicted to heroin are no longer the bulk of the people that we're seeing, and that they need medications like fentanyl to cover the cravings and the feelings that they're having from addiction to the synthetic opioids that are flooded our streets in the last little while. So we are, obviously, I think there are important roles for diacetylmorphine, and some of the challenges with domestic supply limit that. But one of the really important things is access to more options around Fentora, which is a oral-based fentanyl, and fentanyl patches. And that's going to be one of the important things to start with this program.
Camille, do you have a follow-up?
Yes, thank you. There are concerns that people with a substance use disorder won't access this program because they want a non-clinical approach. What would you say to that in terms of meeting the needs of people who are most at risk of an overdose?
Yeah, so there's there's a clinical piece to this, which I think is important right now, especially as we learn about these processes. But the idea of the program and the policy is that it is now an approach that meets all of those needs, that has removes the barriers of a purely clinical encounter. So what we envision is that these will be places where people will feel comfortable coming, where they can talk to a social worker, where they can talk to people who meet other parts of the needs that they may have in their life, and will have access to somebody who can prescribe the medications that are that they need at this time. So yes, there is, I enacted an order earlier this year to allow for prescribing for larger groups of people. But right now the focus needs to be on developing the evidence, knowing what medications are working best and what people need, and supporting the prescribers that are already in the system to be able to support the other programs within the other pieces within the program that people need. And maybe I'll ask Matthew if you wanted to say something about that as well.
Yeah, I think the nature of clinical practice and the nature of even the clinical spaces that we use to treat and to help our community has changed so much over time. I remember working initially in very stuffy clinical environments, very hospital-like environments, and now one of the clinics I work in, called the Foundry, is a very youth-friendly space. It's right across from a high school, actually. It's embedded into the community, and that's increasingly what we're seeing with our clinical spaces as we reach out into our communities. Is we're really listening to the needs of the community, listening to the needs of the folks that will be using the service, and making it more accessible, fewer barriers, more friendly to folks, so it doesn't really feel like you're entering into a clinical environment. So that's part of the continuum, I think, that Dr. Henry refers to, right? Is that we address all of these different facets to make the service and the alternatives accessible to people.
For the next question, we go to Lisa Yuzda, News 1130.
Hi there. I'm just wondering if you can talk about what difference this will make, I guess, in the immediate and short term, because I mentioned earlier that it's going to be 18 to 24 months in this stage 1 before going to stage 2. So how many more people is it going to help right away? And how quickly are we going to see that? Or, following COVID, we looked for deaths to drop off. When will we see this change?
Yes, I wish I had the answer to that in terms of the people being affected. But, we expect this is happening already in a limited way. And there's a number of clinics that we've been learning from where people have been accessing already. But most of those are now filling up. So we do expect that there'll be expansion within the next month. We're getting reports or program plans from each of the health authorities within the next few weeks, and they will start quickly. So yes, we have the supports in place now. We have the funding, and we do expect this program to get started slowly and methodically, but within the next few weeks. And Minister, did you want to add to that?
Just to add to Dr. Henry's comments, we all feel the urgency of the situation. We want to connect people as quickly and directly and safely with alternatives to the toxic supply. The $22.6 million embedded within this year's budget is intended to build out that system, and we can implement quickly, and in fact are already starting to, for example, prescribed fentanyl patches for the purpose of preventing overdose. Being, again, a first in Canada, nobody else is doing this. This can happen quickly through the existing federal SAFER clinics, through the existing health authority programs, and the work that we have to do is to reach, which will take a little bit more time, is to reach the regions of the health authorities that don't already have established programs. But I do want to note that there's some real innovation happening. For example, Interior Health has integrated treatment teams that are going out and meeting people where they're at. You don't have to have a walk-in clinic, and in fact, for some people, it's a barrier. And we've heard people that either have transportation challenges, parental care, or child care challenges, for them to be met where they're at by someone from the medical community is a way that, for example, in Raise My Hands to Interior Health for innovating in this way, I think through those kind of mechanisms we'll be able to unfold some of this additional access to service quickly. In other cases, it will take time to build up. And during all of this, we'll be gaining experience that will then inform, because all of our health authorities are linked together through their own structures and through our Ministry of Mental Health and Addictions. We're going to learn from each other and get people connected to the care that they need and deserve as quickly as possible.
Lisa, do you have a follow-up?
I do. With the, I'm just looking for some tangible numbers here, ballparks even, but with the order that Dr. Henry passed earlier this year about Safe Supply, how many people are accessing that? How many people are you hoping will access it? Like, what will make this a success? What number of people? Is there a percentage? Is there a hard number? Like, I understand that each health authority will come up with their program, but you must have some number in mind to have these dollars behind it of how many there are now and how many will expand to.
Between March of last year, just 2 weeks into the pandemic, when Dr. Henry's order was implemented to allow prescribers to give safer supply by prescription to people at risk of overdose and COVID. Between last March and this May, we had a 475% increase in the number of people that were prescribed safer supply. We also have, in another area of addictions treatment, medication-assisted treatment, which has also had a huge uptake, again, thanks to the people that are prescribing medication-assisted treatment. That's separate from prescribed safer supply. I'll invite Dr. Henry or Dr. McDonald or to speak to what they're seeing in their own regions, but we know that there's demand. We know we haven't been able to reach everybody. The more that we can support prescribers to be able to get more people connected, and particularly working through the health authorities. This is the real innovation that we're announcing today, is that we're not going to be relying only on individual prescribers, but on the team-based approach that health authorities can provide.
It's a really difficult to put a number to things. We're talking in people who have accessed some form at one point or another in the 6,000 people range in the last year. But we know that there's as many as 60,000 people who have some form of substance use disorder in the province. So it is very difficult to pin a number to it. What we do know is that there is pent-up need, there is more need, and this pandemic has really shown us some of the, we've had a revelation in many ways for many people of the scope of people who use drugs and the needs that are being unmet in many parts of the province. So this really is about expanding that access, about finding people that we don't necessarily know about. So it makes it a real challenge. We don't have a specific number. Obviously, what we're trying to address is the number of people who are having overdoses in the community, who are ending up in hospital or who are dying. And so those are numbers that we'll be watching carefully as well.
For the next question, we go to Andrea Wu, Globe and Mail.
Hi, thank you for taking my question. Regarding diacetylmorphine, I believe it was the minister who said that there were issues with the local supply. And so I was wondering if the province had been in discussions with Fair Price Pharma, which says that they've secured a domestic supply and it's available at any time.
Yeah, I know that has been a project that people have undertaken, and there still is a number of barriers about that being available. So we are looking nationally about how to have a supply of diacetylmorphine that's available. There's a number of different parts to those discussions. So yes, we are aware of that initiative. It's not yet at a place where it can be used, but we'd like to see it move ahead for sure.
Andrea, do you have a follow-up?
I do. So we're aware of the issue of prescriber hesitancy and reluctance. We've also heard from physicians who have said that the College of Physicians and Surgeons of BC has audited some of those prescribing safer supply, and that they're worried about losing their licenses or other consequences related to prescribing for this purpose. So I'm wondering, does the college bear any responsibility for making it clear to doctors in this province that they will be supported in prescribing safer supply?
Yeah, so we've had many conversations, and I'll start and maybe turn it over to Dr. Chow as well. We've had many conversations with the college about this, and it is a very challenging place to be in because obviously we want appropriate prescribing of opioids, and one of the things that has been revealed as we are dealing with the street drug toxic crises is that there has been overprescribing of opioids in many different settings as well, and that needs to be addressed. So the college has a role in both ends. This is why I think this program is so important. It's something that I've been advocating for a number of years now, is about doing it in a setting where it is, where we have the supports around, not just for the people who use drugs and need this, but for the prescribers as well, so that we can actually do it in a protocolized way, is the term that I've used in the past. And the college is aware of who is involved in the programs that are happening under the auspices of the health authorities across the province. And I think really important part of that for all of us who are prescribers and for the college is that we are evaluating and understanding what parts of this work and which work best. And so, yes, the college has been involved in this and is supportive of this being a model that helps support prescribers in the best practice possible. And I don't know, Dr. Chow, if you wanted to address that as well.
I would just want to say I agree entirely with Dr. Henry on these points. When I've practiced individually, it can be very challenging. The practice is changing daily. There's so much data to keep track of. The science on this is changing all the time. We're talking about something different here. We're talking mostly about team-based environments, health authorities supported environments where there'll be rigorous evaluation, where different types of healthcare professionals will be working together collaboratively to prescribe these substances and to monitor them. And to me, as as a clinician, that is so very different. That is so very supportive, and I believe that is something that the college would also and will encourage in this sort of team-based, collaborative, evaluative, phased approach. It really is science-based. It really is evidence-based.
For the next question, we go to Tanya Fletcher, CBC.
Yeah, thank you. There's criticism that these measures fall short in actually preventing deaths. The BC Green Party, for example, says the new policy fails to break down barriers. It says ultimately the province is still relying on a prescriber model that puts these barriers between drug users and a safe supply. It'll not be enough to drastically reduce the deaths from the toxic street supply. So can you please comment on that specifically in how this would help reducing and preventing deaths?
So we all feel the urgency of the need to intervene and separate people from the toxic drug supply. We want to end the public health emergency. We've been working as quickly as we can to stand up expansion of last year's guidance, and today's policy implementation, again, first in Canada, represents that collaboration and what we've heard from people who use drugs, what we've learned from people who are on the prescribing end. I'll say again, we are working within a federal model. The Controlled Drugs and Substances Act requires that controlled substances not be given out unless it is with a prescription. And so that's the model that we are working in. And we are very grateful to have a public health office and to have partners as represented here today, Doctors of BC and the First Nations Health Authority and all the health authorities who have got members and prescribers who are willing to step up and do this work, both acting on an urgent basis and working hard to save lives, but also keeping patient safety at the forefront. The strength of the illicit street drugs and the power of the prescribed medications that are being offered absolutely tells us that we need to have the medical community here taking care of patients and doing this work well. That's the framework that we have, and British Columbia is the first in Canada to take this step. And we are, when you are the first, then sometimes it takes a little bit longer than we'd like, but that's the responsibility that we feel. And I don't know if any of the other doctors would like to weigh in on that. Thank you.
All right. For the follow-up, we go to Tanya. Do you have a follow-up?
Yes, please. Thank you. I have a colleague who is watching today's announcement with someone who has to visit a pharmacy daily to get access to regulated substances, and he's wondering if it means he'd be able to get more than one day's worth at any point so that he doesn't have to make this trip. So perhaps in a more logistical or geographical manner, does this really change anything for people already on the program?
Mm. I'll invite Dr. Henry to speak to this as well, but I will say we continue to learn both from people with lived and living experience about the barriers that they face to accessing prescribed safe supply. We want to remove barriers wherever we can. At the same time, we are absolutely reliant on the frameworks that have been set in place to make sure that people both get the support that they need, but also get it safely. And because we have required of the health authorities by the end of this month to provide their implementation plans, now that we have a broader range of both opioids and in the future stimulants that will be available to prescribers, then we will have evolving guidance and framework around each of those, and we will continue to keep in mind removing barriers to access, but also keeping safety and supporting prescribers wherever we can. Dr. Henry.
I think on a sort of practical level, our thought is that, yes, it should, for some people, make a big difference in terms of whether they need to come into a clinic or a pharmacy or go someplace to access medications on a daily basis. Some of the newer medications that are going to be available, fentanyl patches, for example, can be replaced every few days, so it makes a difference that way. Fentora, which is a new medication that's not been used very at all in BC up until now. It probably will need to have stronger restrictions in place at first until we understand the parameters of the drug. So it's going to vary, but I think the important thing is within the program that people can be assessed and supported so that we can try and reduce those barriers, make it easier for people once they're stabilized on a medication to not have to have that daily interaction. And that is one of the things that we hear a lot from people who use drugs, who are using these programs, that it can be very onerous on your life. So there are a number of innovative ways that we're trying to support people in that way. And I think that, as Dr. Chow was talking about, the fact that this is a team-based approach allows us to try different ways of supporting people and removing those daily barriers that some people have.
For the next question, we go to Binder Sajan, CTV.
Hi, Dr. Henry. You mentioned a couple of times there that you had put forward a framework about 2 years ago. Do you think this could have been actioned earlier? I'm just thinking about the last 18 months and how horrible they've been, and just wondering if something could have been done earlier and saved a number of lives.
Yeah, obviously we all think about that. I really think that the framework that we put out was what we adapted to try and urgently address the issues that we were seeing as they came up in February, March of 2020. I think we're shocked and appalled as people who've been working on this for so long, and we're seeing some success, that the measures that we put in place to manage the pandemic really exacerbated things in ways that we did not foresee. And so it was very much a huge tragedy in that way, and it stimulated us to do things like make sure that prescribed fentanyl patches were available. And the initial part was so that we could support people who needed to self-isolate or who were infected with COVID. We were thinking that we needed to support people if it got into a shelter or into communities where people were living in some of the tent communities, for example. But it became really apparent that there was a much, much broader need. So it has been building on what we have learned, and if anything, it has sped up the process, the tragic loss of life that we have had in this past pandemic. So yes, I would have loved it to be faster. I would have loved to have prevented it from happening. And, we can only go with what we know now. We've learned a lot. We've learned a lot about what people need, the substances people need to support them now. And I'm just happy we're moving forward as quickly as we can right now.
Binder, do you have a follow-up?
Yes, I just want to kind of continue to pick up that thread about barriers. I'm thinking about people, most people who are dying are dying at home. And now we're asking people to go to a clinical setting at a time where there's still stigma around this. Just wondering sort of who you see envisioning this program, and maybe if there are other groups out there that still need to be addressed, perhaps in a different way.
Oh, absolutely. And yeah, these are things that that we've been consumed with for some time. And as I said, these are complex, interactive issues, and they're interactive with things like poverty and housing security and food security and all of the other things that are in people's lives. And we've learned, some of the increases that we've seen, and I've spent some time with the coroner looking at this, have been middle-aged men, so people, men in their 50s and 60s who are dying at home. And the things that are leading to that are quite different from much of what this program is going to be about. This is really supporting people that we've been hearing and that we've been seeing who have many other issues in their lives. So it's not going to address all of the problems around the overdose, and we do need to continue to do other measures to try and reach people who are using alone at home. And we, of course, expanded the number of people who were alone at home because of the measures we took in the pandemic. So now, as we're moving out of the pandemic and we're learning the value of vaccination and protecting people and coming together again, the other things that we need to continue to focus on are measures that reduce stigma. This is one of them, because you can get a prescribed medication and it means you don't have to interact with the person who's dealing on the street. It means you know what medication you're taking, so you can have control over your life in a better way. So yes, it will reach some of those people, but we also need to continue the other outreach that we're doing to make it okay for people to talk to their family members, their friends about their drug use, and to seek assistance when they need it, to reach out and to at least have those conversations. And I mentioned earlier that one of the things that I believe is important that we're also working on is decriminalization of people, so that we do remove that one really potent stigma and shame that comes with criminalization of an activity. So it's not going to be there for everybody, but it is going to be there for many more people that do need it, and we've learned that in the last year and a half.
Next question, we go to Lori Colbert, Vancouver Sun.
Hi, this question is for Dr. Henry. You had said earlier that kind of the crux of all of this is the need to expand service and to reach more people. And I'm sorry if this question's been asked, but I'm trying to wrap my head around what's going to happen first in this first phase. We have the urban clinics that are already offering pharmaceutical alternatives, but they're mostly at capacity. So what are next steps to expand service, and how do we get them into rural and remote areas?
Yeah, a really good question. And I might turn to Dr. McDonald to talk about some of the issues in First Nations communities as well that are asking these questions. So what we can see, and we have not yet received all of the ideas from the health authorities and the plans, but we can envision having a hub and spoke model where we have the supports for teams in more rural communities where it might actually be a local prescriber or a physician's offices or a clinic where people go in, but they have the extra supports of the team that are based remotely. We've learned a lot about how we can do team-based care in a remote way over the last 18 months. So I think there's a number of different initiatives, but absolutely trying to expand the access to more rural areas is a really, really important piece of this. And there are a number of ideas that I know are being worked on right now. And did you want to talk about, yeah.
Thank you for the question. Remembering that we have 203 First Nations communities in BC, and about 60% of our First Nations population live away from home. So they live in other rural communities, they live in urban centers. So in terms of directing program, and I mentioned it when I spoke about certain geographies are going to be particularly challenged in this. We have been working with our amazing nurses who work in our health centers and in our remote communities about having them certified to be able to prescribe. Our initial effort is opioid agonist therapies, but as this program develops and as more of our community-based healthcare providers are trained and feel comfortable, we will be continuing to work with our federal government partners. Part of the challenge is the transport of those drugs from the locations where the hospital or clinic in the urban setting, who's going to carry them out to community, how is that going to be done safely, what are the oversight pieces. So there's still a lot of work to be done around that, but there's certainly a willingness. We also have communities who have been nudged off the abstinence only as a model of treatment for substance use disorders, more comfort for harm reduction models, and treatment models that are variable, the on-the-land treatment programs, for example, that have been supported by the government, that we need to be able to look at all of those models and see how this can be an addition to that and engage with people so that they understand the goals of the treatment, where it can be obtained and what the supports would be. As Dr. Henry said, that we're really looking at a holistic program of care that includes these medications, but there's also a broader range of services available to support people in community.
Laurie, do you have oh, excuse me, I think Minister might have a word to say.
I want to thank Dr. McDonald for flagging the role of nurse prescribers. We are very encouraged that we've had 90 nurses step up for either who are already trained or have registered for training, and some of them are actually already out in the field having a particular impact on rural and remote areas. It's more likely to have a nurse in our further flung regions than it is to have a doctor, and they are prescribing medication-assisted treatment. That's different from the safe supply that we're talking about today, but Dr. McDonald is quite right. These are absolutely intertwined, and there is some, we're encouraged that that's getting more people connected to the care that they need. I also want to reinforce the budget commitment, $22.6 million, which is going to accelerate implementation of the policy that's been announced today, that it is hiring directly people that can work hands-on at every level, whether they are more nurses, more mental health practitioners, counselors that can support people on their healing journey. That is, in addition to the comments of the two doctors around how this will have immediate impact, this is a significant budget commitment that's going to expand and support people willing to prescribe.
Laurie, do you have a follow-up?
No, I think that's good. Thank you.
Thank you very much, Lori. We have time for one more question, and we'll go to Shannon Waters, BC Today.
Hi. I've been looking at the death review that the coroner service did in 2018, and basically they recommended that these actions take place years ago, before the pandemic hit, before everything got so much worse. And just in listening to this announcement today, it's very difficult to tell what's actually new versus what is a continuation or an expansion or an alteration of some kind. And so I guess my question just is like, what are the metrics by which you will measure the success of this expansion, and when will they be sort of updated or publicly released?
Thank you, Shannon. I want to start with your reflection on the coroner's reports. The new medications that are available through the today's prescribed safe supply announcement are directly linked to what has been revealed through coroner's reports. That's why fentanyl patches, why Fentora, and why hydromorphone, both injectable and tablet, are now added to the list of what is covered by pharmacare and what is available to prescribers to connect with the people who are in their programs. That's one piece. A second is, rather than relying on individual prescribers, the fact that today with this policy announcement, we are fanning this program out into the health authorities means we're both going to get the team-based approach that Dr. Chow in particular spoke about, what a comfort and a support that is for people prescribing, but it also follows on the work and the commitment of our government to more fully embed addictions care into the healthcare system. We don't want this to be a niche treatment area. This is something that should be embedded completely into the healthcare system, because we view addictions and the overdose crisis as a healthcare problem, not a moral problem, and not a criminal justice problem. So that's the big picture on the government commitment and philosophy side, and consistent with Pathway to Hope, which my friend and predecessor Judy Darcy launched on behalf of the province, and that's the path that we are on. Maybe on the more mechanical pieces, I can encourage our public health officer to speak to. Thanks.
Yeah, I think, obviously, we were looking at this for some time, and the coroner's death review panel was one of the recommendations. I myself put out some recommendations about how this could be done. But now it's being done, and I think that's really important. One of the key pieces that I think is incredibly important, I mentioned this briefly, is that we will have built in both monitoring of how the different initiatives are going, but evaluation, independent evaluation by people who are not committed to this failing or not committed to this being a success, so that we actually understand how the program is working, which medications are working, how they can be best used, and we can support an ongoing evidence base of how to do this in a way that's safe for people who use drugs, but also safe for the programs, and learn the best of the programs. And I mentioned this earlier, but it is important when you're doing something new and different to have a rigorous evaluation. That's what helps us keep things going when there's sometimes pressures, whether it's fiscal pressures or political pressures to stop programs that are controversial. But it also helps us understand how to do the best with the programs that we have. So I think it is an incredibly important piece. It's taken obviously far too long for us to pull this together, but the last 18 months has been a very challenging time for all of us, and no more so for people who use drugs and who've lost family members. So it is an important program. It's an important piece in our toolbox that's going to help us get through this next phase.
Shannon, do you have a follow-up?
I do. I'm wondering if the minister might be able to provide an update on another piece of BC's response to this crisis, which is the application for an exemption from federal drug laws, as announced. I can't remember exactly when now.
I'm very pleased we're moving ahead with. But
Thank you, Dr. Henry, and thank you for the question. So it's now a year since the Premier wrote to the Prime Minister asking the federal government to adopt a national approach to decriminalization. Decriminalization being so important as a way to remove the shame and stigma associated with people letting their family members and loved ones know that they have an addiction challenge. It's, I think, directly linked to the terrible loss of life of people using drugs alone and dying alone. That's what the coroner's report tells us every month is the particular area of loss of life. People that never considered accessing a drug testing facility or a supervised consumption site, let alone talking with their doctor. So we want decrim is important because it reinforces for people that addiction is a healthcare problem and they should talk to their healthcare provider about solutions and safety. So we have been continuing as a government to engage actively with our federal counterparts. I speak regularly with my counterpart and my former colleague in Ottawa, the Health Minister, Patty Hajdu. Our conversations are active and ongoing. We are right now doing the work to build our federal application. It's a very active file and something that the Premier has asked me to fast track, and that is the work that we're doing.
Thank you very much. That concludes today's announcement. Thank you, Minister.
Thank you to all of the participants in the press conference today, and particularly to everybody working on the front lines, working hard to keep people safe, and all those who helped us build the policy that we are launching today. Thank you.